So welcome to the Unmentionables session. This is a favorite of Health 2.0, and we've done this session quite a few times. It's too bad that we always do it at the end of the conference, because I think
we should do it at the start next time.
We should do it at the start. So, for those of you who've never seen a session on the Unmentionables, because we've given presentation about this in the past, but for me, the easiest way to think about these unmentionables is to think of things that are rarely discussed or addressed by health systems, but are really preventing us from being our healthiest selves. Is that how you would?
Yeah, I mean, I'd say the unmentionables are, Alex Drain, who's the founder of ELISA and now runs around the States, sort of poking the healthcare system appropriately. Good friend of ours at Health 2.0, a good friend of mine. Alex says it's basically, sex, drugs, and a crappy boss. It's all the things that, get in the way, that are real life, that get in the way of everyday healthcare, of everyday health. And as Pascal said, they're things that the healthcare system years ago didn't, and mostly still doesn't really mention.
Well, there are also on that list of unmentionable things that you wouldn't think of, or maybe not, I'm thinking about caregiving, for instance. Sure. It's a big unmentionable.
So I think that the way to think about this is that there are a number of things that happen to you in your life that increase underlying things like stress, that increase, and that includes things like being a caregiver, having a lack of community, loneliness, having other issues, and it does come down to things like, lack of connection to society, lack of good sex life. All of that stuff can impact you. There are also, buffers, things which can protect you. But before,
like spirituality,
having good, strong community, having good relationships. But things that cause stress and cause these problems might include, finances. You can imagine that after the recession, the big recession we had at the end of the 2000s, a lot of these problems got exacerbated and got worse as people were finding in financial stress, unemployment, those kinds of things. And the underlying data is very clear that if you have any number of these problems, you're far more likely to have health issues as a result of this. And this includes, by the way, things like some of these issues for kids who grow up with either issues like violence in the home, or having a home in which a parent might be in jail, or living in an environment which has excessive violence. You can see direct relationships to health status and things you wouldn't think of, like heart disease. I mean, things you might think of, like suicide and mental health, but things like heart disease and asthma and diabetes, are all really impacted by some of these wider environmental issues. So the idea overall has been to try to figure out how can you start talking about these unmentioned things. So it's been in the States now since 2011. We've been talking about this pretty aggressively, and I think in Europe since 2013 or so. Mm-hmm. Is that right?
Probably.
So, and I think that probably goes against the trend. And in fact, last year in the States, we didn't actually have an unmentionable session, but we discussed the whole concept of the unmentionables. And the reason we didn't have the session was because Alex Drain, who basically founded this whole idea, said that she, in her work with health plans and with hospital systems, found they now were actually talking about it. They were building programs around, and they were talking about many of these underlying issues, and she felt that a message should come through. Having said that, Indu Sabaya, our partner and our boss at Health 2.0, came up with another list of things that were still not fixed, which she called the unacceptables. A lot of that had to do with inequality in healthcare, poor access to healthcare for minorities, and a whole range of other issues like that that we again aren't talking about enough. And again, so there are going to be issues that are not directly treated by doctors and hospitals dealing with things like diabetes or mental health or what have you, which again we should be stressing. And this session is going to get us at some of those topics.
Yeah, one thing that is quite interesting to highlight is the fact that because we've done conferences in a lot of different places,
Yep.
we've also realized that unmentionables are not the same in different regions of the world. We've been in places where the fact of just being a woman can be an unmentionable and, you know, prevent you from having a real good access to health. So, Matthew, I really wanted you to be with me for this session on main stage for 2 reasons. First of all, we've done our keynotes separately this year, and I've been missing my Matthew time.
Oh, it's so nice of you to say that. I thought you'd rejected me for that Italian guy.
No.
You gave me a separate Italian guy for later, and an English guy and a QPR fan.
Between you and me, we basically accumulate a lot of these unmentionables.
Do you want to enlarge on that topic?
Well, I smoke, you drink.
You drink too, can I point out?
That's true. Okay, I drink. I'm a stress case, but you have mental issues. We can't.
Well, you
To
lot
be
may,
discussed,
you, may
to be
lot think,
discussed.
you lot may think I have mental health issues. I don't.
All right. Jokes aside, we're going to watch a few demos, like we always do, and we're going to start with Conor Farren from Ireland, who is going to present You Control Drink. So this one's for you.
All right.
So Conor is a medical director and a co-founder of eTherapy Health. And today he's going to show us a You Control Drink. It's a smartphone app and platform for treatment of alcohol misuse. It's not abuse, it's misuse. Only 10% of the 23 million alcohol misusers in Europe are in treatment, and this platform helps increase the percentage of individuals who have access to evidence-based treatment. The app has been approved as a medical device across Europe and includes a number of components, including a personal profile, daily drinking log, a recovery log, cognitive therapy, and more. So if you are ready, Conor, we're ready for you.
Good afternoon. Thank you very much for allowing me to present. I'd like to ask you how many of you here are alcoholics. Well, I don't expect too many people shouting, apart from those on the stage. But how many of you...
They're all Health 2.0 team members, I just noticed.
I don't know how long we're going to be able to resist this one.
Well, this is a
It's not
long
open
question.
yet,
But how many of you know an alcoholic? If you talk about your friends, your family, those you work with, those that you've known for years, you'd find that there's actually quite a large percentage, 23 million in Europe. So this app is designed to help those who suffer from alcohol misuse. The first step is that you sit down with your counselor or therapist and you do an onboarding process, profiling not just your alcohol condition, but your recovery stance and your characteristics of your recovery. And then you download the mobile, and this is your landing screen. And so this is your personal profile. My name's Conor, I'm a depressed drinker. That's my recovery points, my gamification element, and my reduction goal that I've already set at the onboarding process. And so that I want to record what I do on a daily basis in terms of drinking. And so I look at my drinking log. So I want to add how many drinks I drank today. So I'm going to say I had a really heavy day, so I'm going to say I had 10 beers. So that's and we see that on my drink log, I was drinking moderately during the week, but on Friday, I went up to 10 beers. But that's not all I want to record. What I want to do is I want to record my recovery activity as well. So I go back to my profile, and this is a log my recovery activity. And so my recovery activity I've already pre-boarded so that it can be such things as going to an addiction counselor. It can be general recovery, such as going to the gym. And I'm going to record that I went to the gym. In my activity log. And shows on Friday that I went up 1 or 2 sessions. So that I record drinks together with my activity, my recovery activity. And this is sent exactly at the same time to my addiction therapist, who can watch it and can monitor it and can decide whether an intervention is required. But also added in are my therapy sessions. There are 12 research-proven cognitive therapy sessions based and built into the app. And this is, I'll just give you a flavor of what some of them look like. This is an introduction. There's an introductory video that's played, some information about control beliefs, and then a questionnaire in which I answer questions according to my personal profile. And I only got 4 right because I didn't really answer them very thoroughly. So this is inbuilt, research proven, and it shows what you can do with the components of the app. Also, and very importantly, there is a craving button built in. My alcoholics at 3 o'clock in the morning don't know what to do. They're staring at a bottle of wine and they want to know what to do. So they can press the calm button, the craving button. They're given instructions immediately according what to do, move to a different location. They're given 10 seconds to engage with that. They move to the next instruction, which is stay calm. Give them 10 seconds, and then they get played a calming anti-craving video. I'll give you just a few seconds of that to show what that feels like. After 1 minute, which I won't wait, in the calming video are presented the reasons to change, the reasons to stop drinking, the reasons to do something different that you onboarded on your onboarding profile at the very beginning. So it's extremely personalized, and it shows the how to make it effective because of the timing of the administration. Finally, there's weekly stats. So this shows that I've completed my weekly task, 33%. This is how much I've reduced my drinking relative to my target. This is whether I've actually avoided all the triggers that I said I would and engaged in the recovery activity. And this is whether or not I've completed my therapeutic interventions for that week. That is relayed simultaneously to my therapist, and so they can see my profile and my weekly stats and intervene as required. Finally, get a text message twice a day at 8 o'clock in the morning and at 8 o'clock at night when I'm setting my plans for my day and also the time that I'm most vulnerable to drink in order to keep that motivation going. And that's You Control Drink. Thank you.
Thank you. Come and sit with us. So that's the question of behavior change is always a tough one to crack, but especially when it comes to addictions. So can you tell us what you think in your platform is really going to be the elements that are important differentiators and will help these people achieve their goals? When you look at, I mean, there are other solutions. You're not the only one. What makes yours?
There's 3 elements to this. First of all, there's the psychological element, the cognitive therapy built in, and that they can access whenever they want, not just when their therapist is available. So that's the first element. The second element is the behavioral monitoring, a drink log, but very importantly, there's a parallel recovery log, so that as you reduce your drinking, as that achieves over time, you track what changes in lifestyle that match that reduction in drinking. And thirdly is the element of personalization. Is that on the onboarding process, all the elements for your recovery, going to a gym, going to a counselor, all the elements of triggering that you need to avoid, avoiding stress, or indeed all the bits that make you crave, and all that is played back to you personally when you need it, either when you're sitting in front of, on the way home on the bus, or at 3 o'clock in the morning when you're staring at a glass of wine. So those 3 elements make it more effective than a standard app.
So I'd be interested, Conor, in this. So there are 2 elements here. One is that you stressed many times during the presentation that this should be done in conjunction with a counselor. Mm-hmm. Obviously, there are numerous programs, the best known as Alcoholics Anonymous, where it's a sort of community group therapy, if you like, which may have a counselor or you may have an individual sponsor who you represent with. So I wonder if that works in those areas. And then the obvious other thing which is going on is that if you're asking people to log their own drinks, most people are we know this in food diaries, most people tend to log, unless they're being really meticulous, tend to sort of ignore that piece of chocolate cake. I mean, have you got any data where you've sort of cross-checked the self-reporting part amongst this as well.
Yeah.
So it's two separate questions, I know. But
I'll answer the last one first. The issue about self-report, interesting, and alcoholics have done research on this for about 15, 20 years at Yale and at Mount Sinai and at home in Trinity. And basically we get a 93% accuracy in terms of self-report relative to objective measuring, be it objective measuring in terms of blood alcohol or objective measuring in terms of a researcher evaluated. So actually they're quite accurate.
pretty good. So you can remember at the end of your 10 beers that you've had 10 beers, because I struggle after about 3.
Or you can actually do it as you go. And so it is research proven to be reasonably accurate. And the other 7%, they tend to lie consistently. So they tend to say, okay, I only took half the drinks that I actually did. So, and also you're using them as an individual parameter. You're setting the target relative to their baseline drinking. So consequently, if they lie a little bit, that's okay. We're aiming for a percentage reduction, maybe even 100%, ideally, but maybe even a 50% reduction, and that's okay because they've already determined what their baseline is. And so absolutely, we want to create an online community. So the next stage is that our users are going to be integrated into an online community. There's plenty of ways that the technology support that. And at the moment, it's the app as it is, but the next stage is to create interconnectivity between patients. Already in the cognitive sessions, there is videos of personal stories and so on that do enable you to connect. But ideally, yes, we would have not just a real community, but an online community.
Interesting. The other, so that's sort of, and in terms of, has it been used with, I don't know if in your work so far, has it been used with other communities like Alcoholics Anonymous, or has it all been therapist-driven? Or is it, or is there and then the next question is there a self-service element where
we did initially develop it and as a standalone. And so we tested it as a standalone, and you'll see that it's a very simple, straightforward journey. So it was developed with the user journey purely from the client point of view. But what we found in user testing is that if you onboard with a clinician, you get much more buy-in. So instead of a direct B2C, we actually pivoted and we said, right, this is really a B2B. So our main target is hospitals, clinics, individual therapists, so that there is that engagement, that buy-in at baseline. Once they're engaged, once they're they can be left to it, and maybe followed up once a week, once a month, once every 3 months. And it can be used in a post-rehabilitation situation, or indeed straight off the street, as it were. But we do like that onboarding process to be personalized. So that's why we aim to have a therapist really at that beginning point.
And the one other comment I'd make is there's a startup I know in San Francisco called DXRX. I don't know if you've run into these guys yet. Founded by an addiction specialist physician. I don't know how you become one of those, but and they use a combination of drugs and a program not quite like yours, but it's a sort of telehealth drug-based program, and a prescription pharmaceutical which is designed to reduce the dependence on alcohol.
Yep.
I can't remember the name of the drug, but apparently it's relatively rarely used compared to the number of alcoholics there are. Mm-hmm. Have you thought about doing that sort of combined therapy, using that would be kind of a beyond the pill approach, as it were? Coming to that previous panel, have you gone down that path?
Yeah, there are a number of pharmaceutical companies working in the field of alcohol abuse, and unfortunately, it's a hard market to crack. And so I was working with one of the major pharmaceutical companies working in the area, and just at the point where, as in the previous session, where marketing got involved, they kind of said, look, we're not so sure we want to invest the next X amount of millions involved in it. But interestingly, Pascal, the one country where pharmacotherapy for alcohol is really taking off is France.
Actually, where I live, Bretagne, is where we're doing all the testing.
Well, there is a wonderful story about a physician called Amicia who died of alcohol-related problems, but he developed a pharmacotherapy for it called baclofen. And so in France, baclofen has really taken off peculiarly in France, and so that has meant that other pharmaceutical companies...
It's a mild antidepressant, right?
It's actually an antispasmodic for multiple sclerosis. But at very high dose, it decreases craving. So it has meant that there's an opening in France and in French-speaking countries for any pharmacotherapy for alcohol. So there is hope that pharma, and wonderful thing about pharma, it can be criticized, but the wonderful thing about pharma, it produces patients. pharma invest, they engage, and so the ideal would be that this would piggyback onto a pharma company, increase retention, because this is a retention tool, which is the core thing in the treatment of addiction, is actually treatment retention, and then it would increase their pharmacotherapy engagement as well.
Just one last question. You prefer to use the term alcohol misuse?
Again.
Is there a reason?
It's on the gentler side. The research term alcohol-dependent, alcohol use disorder combines into the phrase alcohol misuse. People aren't afraid of the term alcohol misuse. If I say you're an alcoholic, you'll react. If I say you're an alcohol misuser, let's talk about it. Much different level of engagement and support. And clearly with the personalization of the app, the whole idea is to get you, the alcohol misuser, involved and engaged in the process, not me telling you, the alcoholic, what to do.
I've always said that I didn't abuse alcohol, it abused me. But
No, but one of the principles of AA is no exception, right?
Correct.
But when you use the term alcohol misuse, what you underlie is that there is an appropriate or an okay use of alcohol,
Yes.
right?
The research shows that about 50% of people with an alcohol problem don't want to know, but 50% do, but only 10% actually engage in treatment. So there's this great 40% which something like this could access, because you don't actually have to go and embarrass yourself in front of your family doctor. You can actually do this relatively discreetly. Hopefully it will be freestanding in the not too distant future, and then use the technology to engage and allow you to make that recovery journey, maybe not 100% on the first day, make the journey towards hopeful long-term absence, but it's a step-by-step process. It's not the actual complete abstinence that AA demand.
yeah.
All right. Well, why don't you stay with us while we watch another demo? We're going to go to a different sphere. It's the psychiatric dimension. So we have Daniel Novak with us, who's the... Actually, this is not Daniel.
No,
sorry.
Pavel.
It's
Nevicky.
Pavel. Sorry.
Yeah.
We have Pavel, who is representing Mindpax. It's a solution that predicts and manages psychiatric mood disorders with wearables. Mindpax provides physicians with continuous information on sleep quality and physical activity of psychiatric patients, giving them objective information on disorder development. Mindpax is provided as a SaaS platform where patients receive their proprietary wearable for free, and the wearable can last 6 months with no need for charging. If you're ready for us, we're ready for you.
Yeah, I'm ready. Good afternoon, everybody. At the beginning, I'll just give you a short narrative about the disease that we are trying to tackle, because as you have said at the beginning, mental health is one of the unmentionables. Even though during today and yesterday we've met a lot of people and our stand here telling us that somebody close to them suffers from the bipolar disorder or unipolar disorder, and if there is something that we could help them with. The bipolar and unipolar disorders are basically characterized by the facts that the patients suffering from these disorders typically go through the deep valleys of the depression and the high peaks of mania, and these acute states lead to the hospitalization. The hospitalization can take something between 1 and 3 months, and it's very stigmatizing and troublesome for the patients, and it's also very expensive. Our idea that we came with was let's try to predict somehow on the objective information that the relapse is about to happen, and help the patient to avoid the needed hospitalization. Currently, the approach with the physicians is based on a discussion, on an interview. So the patient comes to the psychiatric ambulance, and basically the mental health specialists ask him a sequence of questions, and based on this decides on how to treat this person. However, this takes place only a couple of times a year, sometimes only once a year. So there is no continuous information. What we have done is that we have built a variable that lasts, as you said, up to 6 months. And the variable is varied by the patient, and the variable sends on a daily basis information to our data storage, and where we calculate with the predictive analysis the predictors and compare the individual predictors with for the patient with the healthy group. This is just the visual summary how the raw data collected from the wristband look like when the physician receives the data, and the light blue rectangular area basically is calculated the length of sleep. And as we know that one of the important predictors are the shifts in the sleep, this is the first visual thing that could be used by the physician. Then more complicated thing that gets to the physician are predictors that are based on multiple studies. The first column basically shows the individual figures of the patient. The second column shows the figures of a control group. And our system generates an alert to the physician. So if there is something statistically substantially different between these two groups, it generates the alert to the physician. And as this happens 5 to 6 weeks before the relapse actually happens, the physician has still sufficient time to call in the patient and have the deep interview and adjust the medication and avoid completely going to the hospital for the patient. We have built it on a system that we are using for the schizophrenia as well. And in schizophrenia, we have also went already through 3 clinical blinded studies that has given us 70% of accuracy in prediction of the relapses. That's all from me.
Thank you. Come and sit with us. So that's pretty interesting. So we can with the sleep patterns and other elements like that, we can predict episodes.
We can predict the actual episodes, yeah, that are the most troublesome and most difficult things, or the time that the patients need to go through.
And it needs to go through the doctor, or could you actually tell the patient directly? You know, it seems like you are entering this phase.
That's actually a very good question, because the patients, it's a lifetime disease. And the longer the patient is living with the disease, the better he understands what is going on with him. And many of these patients are so-called self-medicated. So when they have this feeling that the attack might be coming closer, they just can on their own increase or decrease the level of medication.
And usually they're right about predicting feeling.
If it's based only on the subjective feeling, they are very often wrong, because they are losing the insight. They just don't understand properly what the body is telling them. That's a physiological thing. But with the objective measurements, it just dramatically helps, and they can do the adjustment of medication by themselves.
So is it just sleep that's the
It's mostly sleep. It's mostly sleep, but it's also a physical activity. Simply saying when the person, and an important thing is that we need to monitor the person very long term, because on average, the relapse occurs once in 18 months. So we need to have the information for a very long time. And if the long-term trend shows that the person behaves the way that he moves less and at the same time has been diagnosed with bipolar disorder, there is a high increase in the probability that the depression might occur, simply saying.
And then back to the same, sort of the similar question that I asked Conor about about people tracking. What's the compliance level? Do you find people taking the risk, when they go into an episode, taking their wearable off and sort of getting off the system? That's obviously an indicator in and of itself, but I mean, do you only find that the people who want to deal with this are the people who, are trying to self-medicate and deal with it anyway?
It's interesting that when we talk to the patients, most of them, they are in the group of unmentionables. They don't talk about it. They don't want anyone to know it. And at the same time, they are willing to do anything to avoid the need of hospitalization, because being locked up in the psychiatric hospital for 3 months and losing the contact with the outside world is a huge burden. So they are willing to wear whatever if it helps.
And are you tracking as well with this? Is there a way that I didn't see it on the system, but are you tracking medication use as well?
Yes. The data are going through the mobile phone application, which I was not showing, but the mobile phone application also provides the patient with the reminders on that he or she needs to take the pills on a regular basis. It allows them to log in the substantially important events that can start the acute episode, and it also gives them some fitness-like information for the high adherence, like how many steps I've taken, how long I've slept.
And what level of compliance or what level of, between of the people who are wearing the wristband, what share are sort of accurately or relatively routinely completing that information as well? What share, what percentage are accurate, are completing that other information? So, for your data set to start looking at.
Like how important are the objective data?
Well, I'm just wondering how many, you've got the objective data.
Yeah, we've got objective data, but we are also using the other data to improve.
Data, right?
Yes.
I'm just wondering what percentage of people who are currently using the wristband are also fairly routinely reporting the self-reported data.
It depends. We don't ask all of the patients, so it's always on the discussion with the psychiatrist, because some of the patients are either too old to use the mobile telephone, or it's too complicated for them to just answer on the questions. But when the psychiatrist decides this is a patient that need or is still in good shape to answer, there is a very high level of adherence. It's about 80 to 90%.
Is that high? That's remarkable.
One of the problems is people going completely on vacation from their vacation, right?
Yes,
with this type of patients. Do you find that being able to adjust the treatment to what you might need in the next few days actually prevents that?
Yes, because what we are looking on, it's a very different from other variables, like when you are monitoring pulse or temperature. It's just those are only the snapshots. But what we need to do in these chronic diseases is having this longitudinal data, very long data. So it really doesn't matter if you go to the vacation or if you have some big thing to get ready for, like preparing the conference or whatever, you sleep less. It usually the people think that...
Really?
Usually people think that it will show up in the data, but in the long run, there is almost no substantial difference.
And do you have how many patients have been using this so far? For how long? And what kind of data do you have about the improvements?
So far we have 300 users, and we are running 2 controlled studies together with the National Mental Health Institute in Prague, and the figures that we are getting are similar to the schizophrenia thing. It means the accuracy is close to 70% to predict the relapses.
And are you able to intervene in those? Are you seeing the ability to intervene earlier, and actually reductions in these episodes?
Yes. The trouble with the psychiatric drugs is that when you give the drug to the patient, it usually starts working only after a couple of weeks. So the earlier we can identify that the relapse is about to happen, the better for the patient.
Right.
All right. Is it time to talk about sex? Who was that?
It's Rebecca.
Of course. All right, so let's talk about sex with Anatol. Anatol Menon Johansson is the director of Sext, which is a great name, I think, whose mission is to support access to sexual and reproductive health services. The real-time database helps providers communicate their services and hours and lets clients know which services are available, where they are located, and when they're open. Early stages of Sext have been shown on our stage at Health 2.0 in the past. We remember. But in the past few years, Sext has grown, including a grant from Public Health England and the Cabinet Office. Today, Anatol will be showing us the partner notification tool that allows a user to anonymously inform partners of a sexually transmitted infection. All right, it's all yours.
Thank you very much, Pascal. It's good to be back. So I'm going to be showing SXT, which not only signposts for people for infections, but also helps women find contraception in real time. And worldwide, every second, 11 people contract an STI. And of course, many of those are silently transmitted, and people are associated with sexual networks. So inside of SXT, we're getting people to services already. We thought, well, can we use it to tell partners and then help them access a service? So it's a simple to use, he says. Let me just go onto the website. It's a simple to use web page when you get access to the internet, and it allows you to immediately start telling partners there and then in the clinic, but then also allows the patient who has the infection on their mobile phone to do the same when they leave the office. Okay.
Try Health 2.0, one above it.
Okay.
It's Fear of Barcelona, capital F, IRA, capital F.
IRA.
IRA, lowercase b, Barcelona.
Barcelona, yeah.
Try that.
Thank you very much. Saving my bacon. Okay.
Assuming that works. Come on.
Brilliant, thank you. So the idea is that you can tell as many partners as you want. And so here we go with this is a test. And in this case, we'll talk about hepatitis A because we have an outbreak in London at the moment. And we'll talk about gonorrhea. And you ask the person how many partners they've had in the look-back period and how many they can get in touch with. And then you proceed to the next step. And at this point, you can start telling partners. And what's nice about this is it's default anonymous, but you can uncheck that and you can give your name. And you can use SMS or email or both. And I have already a number saved here, and you can see the message down below. So that's it. This first partner is being told, and you can, as I said, you can tell as many people as necessary. And when you do tell partners, then what happens?
Great, Anatol. Every time we meet, there's something. So now I might have hepatitis A and gonorrhea.
And gonorrhea. Congratulations.
Thank you.
The most we've transmitted, there's a text message coming in on my phone as well. The most infections have been transmitted in one message of 4 infections. And it's important we do so. And 20% of people who are told are actually told outside of being informed in the service. So actually a lot of partners are not declared to the service. So step 3, we just send a link to the person who has the infection's mobile phone. And then we capture some simple demographics, and then the job is done. Now, what this platform does is then allows you to see what's happening. So you can see that we've actually told 2 out of 4 people, which is really good. And then for the person who's received the message, you can see that you end up getting a message that allows you to then, look for a service. And here's one I sent earlier to myself, but it's when I was Andy in this case. And it tells you exactly, well, let's go back to the Bob one. Let's be realistic. So it tells you exactly where where local services are. And I've already set this up to work in Barcelona, so you can find a local clinic once you've read the message. And it tells you in real time what's open, and it only sends you to clinics that are appropriate and actually can serve your needs. So we make sure that we don't send partners to places where they can't be managed. And this is BCN Checkpoint, which is just around the corner from here, offering a great service, in this case for men who have sex with men, but you can add in all the other services and it helps them get there. So what's really nice about this platform is it gives them the information not only to find the clinic, but also to navigate the clinic, because sometimes you turn up to clinics and they're busy, so you click on the link to show the receptionist, and then this partner code you can actually then add into the system if they're using SXT, but if they're not, they can use any browser, and you can just put in the code, which I'm just copying off from here. See, and it allows you then to take the sexual history from the partner who's turned up, who may unwittingly be linked to the sexual network. It allows you to see the infection that they've been exposed to. It allows you then to give the vaccination if it's hepatitis A and it's within the last 2 weeks. It allows you to test and wait if it's gonorrhea and it's more than 2 weeks. And then again, you capture the demographics in the system, and that allows you then to sign them off. And when you do this work, it then actually tracks it in such a way that you can see that two of the partners have been told, but actually one has been informed in the right-hand column. And overall, the clinics are now having real-time analytics page, so they can see where they're performing in terms of partner notification. So we're stopping the spread of infections, we're reducing the cost of diagnoses, and we're dealing with what is the most difficult job in sexual health. Thank you very much.
Thank you. Come and join us. It seems like from the last time we saw it, it's been a great evolution.
And I said, but it's actually the last time I saw this, there's a couple of similar ones in the US that I'm involved in. One was InSpot, and one was Say They Can Know, but you've gone a long way beyond that now. So how much of, where is this in terms of within the UK or elsewhere? Is it being used as a tool by sexual health clinic? Pretty powerful record and notification piece, but also the back end for the clinics as well.
Well, the Public Health England grant was for a HIV Prevention Innovation Fund. We've had 17 partners of HIV confirmed through this platform. We know that 25% of those will be HIV positive, and we know that 3 out of those 4 people will be undetectable within half a year on treatment and will no longer transmit HIV. So we've already proved the case to the Public Health England. Public Health England have actually started using this tool for hepatitis A because they find the most difficult thing as a public health department is calling someone up who has a contagious disease, and you get their household contacts, no problem. But when you start asking about their sexual partners, there's no conversation. And this is the same problem that public health departments all over the world have, is that suddenly their partners are not contactable. All the sex is then described as happening in a dark room. We have no way of getting in touch with them. And in reality, we know from the SXT platform that instead of 40 partners being contactable for every 100 people with syphilis, as there is from a study in the USA, we actually know there's about 220 partners that are contactable for every 100 cases of syphilis. So we know that when you give people a private, anonymous tool, that more communication happens, and we're going to get more people told. And the challenge for us is to make sure that people who get the message, they open the link. At the moment, it's 2/3 are opening the link, so we're sending reminders now, and then we're scrubbing the number of the partner or the email address of the partner. And the other challenge is they turn up to clinics, and the clinics don't engage with the platform, even though we've made it very simple and working on any browser. So it's healthcare worker initiated and signed off, but we also allow partners to self-declare that they've been seen and treated, which is really important.
The message I received said, Pascal, it's Anatole, since we last met. So I assume there's a way to do it anonymously.
It's by default anonymous. I only said it's Alice Holf just for the demo, but most people don't check the. So by default, it's anonymous. But if you uncheck it,
you didn't want to worry me.
Yeah, exactly.
It was not part of the demo.
But sometimes people do want to uncheck that and put in their personal details, but a lot of people don't. And
I was just you wanted to declare who'd given you Hep A and gonorrhea. It could have been anybody, but in fact it was Alice Holf. It was deliberate. It was me. I did it to you.
In that dark room.
God knows what.
Fiera Barcelona.
Yeah, so the biggest challenge is people will look you in the eye and say, yes, I will tell my partners, and then they go away and they don't. And of course, what we're trying to do is encourage people to understand that if they do tell their partners, that they'll stop the infection coming back. And from the National Chlamydia Screening Program in the UK, we know that when we test young people after 3 months, we find instead of 8% having chlamydia, we find 15, 16% have chlamydia. So clearly they're not telling other people in the sexual network, and then it comes back. And this is a very old story. There was a wonderful play, La Ronde, by Schnitzler, and it was all about syphilis going around 10 people in the play. And that was from 100 years ago. And this is the same story happening now. And until we start doing really effective partner notification, we're not going to reduce the cost to diagnose these infections. We're going to carry on spreading these infections. And when it comes to things like hepatitis A, they say our current outbreak, we're putting people at risk of severe hepatitis and potentially death. So it's really important to get people told and get them vaccinated promptly.
Mm. Yeah, no, it strikes me that I'm on the board of this organization in the States called YTH. For those of you back in the States, I'm having a conference next week, Sunday, Monday, Tuesday. In fact, that's in 2 days. So, there is tremendous potential. The group that uses, the group who's most at risk, which is sort of, mid-adolescents through to young adults who are most sexually active and it's kind of like it's the inverse of everything else that we talk about in health technology, because we're always talking about, okay, you've built this cool tool for, seniors with diabetes, and they're the ones who are struggling. But these are the groups who are already on all these platforms and using them. So it's this great advantage. Of course, it's very hard to get people to discuss this because it's such a taboo topic. And as you said, we've struggled in other ways. But there's so much potential for using these tools for things like, sexually transmitted diseases. And, I think some of the evidence we've shown, as you said, is if you could really get at this, things like chlamydia, you could break the cycle completely if you can just get people on that. But the other side of it, as you said, is that, and I'm interested in seeing how that develops, is that there haven't really been tools that the other side, the clinics, have been able to sort of log and use, and you've developed those now, so really great to see how that goes.
And it's great having real-time data because we now have clinics competing with each other to see how well they're doing for partner notification, right. And we have a national target that 60 partners should be seen and tested within 4 weeks, and clinics are looking at that target and getting a little apprehensive when they fall below that target. And the other thing about having real-time data is you can say, well, it's not working so well in black women, for example, with Trichomonas vaginalis versus Caucasian men with syphilis. So you can say, well, what's happening? Is it the provider that's dropping the ball here, or is it the patient? What can we do to work with them to improve the service within specific groups? So it's exciting data.
Very good. Well, it's been a long effort for you working on this, and it's been very impressive progress. So
yeah, the first version we've seen, I think, was text-based.
Yeah, that's exactly right. It was text message only back in Berlin, the beginning. Yeah,
absolutely. Fantastic.
All right, well, congratulations.
Thank you.
Let's continue talking about intimate health. This time with Elena, we're going to talk about women's intimate health. So Elena Torres is the co-founder of BeWom, which is focused on women's health and wellness and self-care by highlighting prevention, care, and tracking of their intimate health, such as pelvic floor. It shows I'm an expert. That's sex, urine leaks, and emotions. Today, Helena will show us the mobile platform that is making access to these tools easier than ever.
Thank you, Pascal. So, hello, everyone. I'm Elena from BeWom, and we are changing self-care for women. You know, women, we are complex. We go through many changes in our life, and we don't prepare for that. So here it's BeWom to help on that. I'm going to show how the app works. So the first thing you see, you go to your homepage. It's completely personalized for you. And why? Because before, when you have downloaded the app, you have answered some questions, and something like, at what time do you eat? When do you sleep? Because if we really want to help you, we need to know you. What are your habits, and when really we can catch you and tell you or warn you or alert you, now you should be doing something. But we also ask questions about other issues, like can be pelvic floor or intimate health or sex also. That's why we are in the Unmentionables. And when you answer the results, you would see the results compared to other women that have answered the same as you. So you can see how is your situation. That might be common, but not normal. So going back to the timeline here, that it's your homepage, sorry, it's the computer, you can scroll down, and then depending on what you have answered, you have a goal. In my case, I had constipation. So I go here, and when I open the app, I saw you have 1 minute, read something that it's about constipation, and that it's a tip that will make you healthier. So let's go back, and I say, I have my goals, and my goal was constipation, that it's for 4 weeks. I already had done less than 1 week, and I can see and track how many time I have dedicated to that goal, but I also can pause it and dedicate to other goal if I want. So going back again, sorry, and yeah. So we scroll down, we go down, that's my personal page where I have everyday new information, exercise, and my coach is maybe asking questions. And in this case, it's asking, do you have 1 minute to answer some questions? And yes, of course. And this now is asking things about urine leaks. And there is a test that I'm answering. And here, it's very, very fast and very easy. You go down, you answer. The idea is that with few information, we can have more personalized everything for you. So we can give you the information very adapted to your needs and to your goals and to your moment of life, because we think also that information is power. So we scroll down again, and I cannot scroll. Why? I don't know why. That's a computer, and I'm used to a tactile one. So, sorry.
Didn't help.
Yeah, here. Yes, I found it. So here, today, I have some exercise to do, but if you see, my goal now, it's avoiding the urine leaks, and it's pink instead of purple. So I can do my exercise, and the app will track it, but if not, because it's so easy that I have learned it by heart, I can make a note and say I did the exercise, and in this case, I did it on my job because I did it just right now and you didn't realize. So I keep it, and I will have it in my calendar, and I will see the evolution. So the idea is we really can change self-care. We can really have a healthier life if we know where we are now, and we do teeny things that doesn't take very much time from us, and will improve our healthier life after. So let's change self-care together. Thank you very much.
Thank you, Elena. Come and sit with us, please.
Yeah. Thank you.
We're going to squeeze up, Helena.
So we talked earlier on about consumer health, and I wanted to ask you what was your business model? What was your approach to the market?
Okay, we started like a B2C, so to consumer, because we wanted to test that this really worked and that we were able to engage and there was interest from the users. And we started only with the pelvic floor, like a pelvic floor training app. And after 2 years, we realized that we had to do something else. It's not only about the exercise. It's about education. It's about including teeny things in your daily life. So what we really have to help is women in their daily habits. And one thing, of course, is the pelvic floor, but there are more things, because we look health as an holistic way. So emotions affect us. We have also the menstruation. We have our cycle. We have the pelvic floor issues. We have kids at some time. So we have to cross everything. So that's how we started. Now, since the beginning of this year, we have started a model of B2B. B2B2C. So the idea is that insurance and medical institutions can really pay for that, because it really improves the health of the patients. Let's say the example of the insurance. You know, the pyramid was like that, but now the geographics are like that. So we are getting elder people that we need that they are healthier, or we are healthier. Otherwise, the health system, both public and private, won't be able to afford it. So really, self-care will be there. Let's do it with B1. So insurance could help their users to prevent, because they will have a healthier life, so they will spend less money in medical treatments. And that's a cost saving for them. So now we are in that moment.
All right, and how good are the women at always going back to the app or to the solution?
Yeah, so that's something we learned also during these 2 years. The adherence, it's a problem not only with the apps, but also with medical treatments in general. We went to doctors and they said, yes, they start, and when they feel a little bit better, just they drop it. And so we started to see this with the app. That's why we changed all the experience. And that's why now when you enter the app, you have every day something new that doesn't take you time. Because we don't have time. We have a friend, a daughter, a son, a mother, whatever, but we always have something to do that it's not for us. So we have to take really, really few time. So now the thing to increase the adherence, and that's what we are doing, it's that every day there's something new. So you have 5 minutes to learn something new or to do something for you, yes.
So the app prompts you to read something. You receive a text,
it's reading, or it's an exercise. Yeah, that's there's a message. It's a push notification, and that's why at the beginning of the app we ask you, how are your habits? When do you eat? When do you sleep? When do you have a relaxed moment? Because if we really want you to do something, we have to do it at the right moment. Not at any time at 5 o'clock because it's when we want. No, it's when you really can do it. We have to adapt to your life. So our app, it's learning about you. And every time it's more personalized and more adapted to what you need.
So it retains the information. It says, if Elena was able to read that message at this time, it will keep the information and then adapt. That's smart.
Yeah. So that's the idea. And this increases the engagement and the adherence of the woman.
Can you tell us a bit about the business that you're running now? So, I mean, how many downloads, how are you distributing it, how are you advertising it?
Yeah.
I know I have a sticker on the back of my iPad that says I'm doing my Kegels right now. I just tweeted it just to amuse Rebecca, actually. But
you know, I have the other sticker here.
Yes,
too.
well, that one's fine too. But I may be too old for that one. Go on, tell us your new phrase.
Okay, an orgasm a day, keep the doctors away.
All right, but tell us about how you're going about distributing it. How about you advertising? What number of downloads and users do you have? How's that working?
We have 200,000 users around the world, registered users, that have answered more than 11 questions, and now we are increasing the questions, so we have more than 3.5 million health data points nowadays. It's distributed 40% in Spain, 40% in Latin America, and 10% in North America, and 5% in Europe, and the rest it's spread around the world. And our advertisement is mainly Facebook ads and some influencers, but we have around 40% organic downloads. So that's the great thing, that the word of mouth, it's working.
And what about relations with, I'm wondering about sort of ways that you would promote this organically. Obviously there's sort of, more commercial advertising plus, magazines and just sort of general health channels. What about with professionals? Is this something that people are talking with their gynecologists? Are you pursuing that? Has that been an effective channel for you?
Yeah, we are starting with that because we had few resources until now, so we had to few hands we had to focus. But we have realized, I have friends that they came and we say, oh, I'm doing B1, and said, no, my gynecologist told me to download it. Really? Yeah, or they had not talked to me, and they were recommended it. So they find it's a good tool because they don't have time to educate their user, their patients, because they have 20 minutes and they treat at that moment. They cannot be 1 hour educating what they should do. So our app, it's complementing their service. So yes, now we are building an ambassadors network so they can really spread the word about it.
Yeah, I mean, I'm wondering, you know, this is one of these things. I mean, as you know, we were discussing out in the exhibit hall last year at our Traction in the US, a tool called Virginie, which is a, how would you describe Virginie? An insertable exercise tool for women that actually helps them, you know, do their Kegels.
I would say it's a Fitbit for pelvic floor.
A Fitbit, that's good. Very good. You know, won our Traction contest. And it's kind of indicative of a number of interesting things that get unmentioned. Number one is that you are running a startup about a particular issue, as is the CEO of Virginie. All kinds of disadvantages, honestly. Female startups, an area that most male venture capitalists have never heard of, let alone understand as a problem, and if they, you know, are kind of shocked about and wouldn't invest in. And finally, one which is probably not discussed properly by the medical profession, because it's not regarded as being, and speaking as the son of a gynecologist, not really regarded as being that big a deal, whereas for women who have problems with, you know, starting with pelvic floor, but other issues that are around that, like constipation, you know, these are things that are kind of more inconveniences than regarded as being hardcore medical problems. But obviously, it's one of those things where you can imagine there's just a huge market out there if you could figure out how to reach it, and the amount of good you could do is huge if you can grow that. So 200,000 is a hell of a start, but there's 3 billion women on the planet, right? Many of whom, and some men too, right, who've got many of these problems. So it's one of those things you've got to imagine, how do you pursue this in multiple channels, both sort of virally on the consumer market, and I'm wondering who would be a good partner for you to help you go further. What do you think? If you could pick your ideal partner, who would it be?
Okay, my ideal partner, I have some in my head, but I guess a big pharma, because they need the data mainly. Mm-hmm. So our main client would be an insurance, but our partner would be the pharma, so we can get both.
But I also think that this is kind of the thing where we need to raise this above. This is very similar to many other issues we considered, all the way from, you know, wanting to admit that it's not that you have to admit well, it is. You have to admit you have a problem with this, just the same as everyone else on the panel is dealing with. My sense is that, you know, it's understand this is something that you can talk about. It's kind of like, you know, Tupperware parties, and can you get groups of women and others together to exchange information about this? Can you get magazines like Cosmopolitan to really focus on it? I mean, a lot of these issues just, you know, haven't been described enough. So I think it's one of those areas where it's an unmentionable, and we need to sort of break beyond that. And to that extent, you know, you've seen other problems which, you know, people didn't used to talk about, you know, now coming out in the open, things like around obesity and food addictions and things like that, you know, that now people are starting to talk about. Obviously, alcohol is one, Conor. And I think that this isn't an addiction, but this is one of those problems that just needs more exposure.
Completely. And we're trying to break taboos at the end. And however, there are cultures that it's more difficult than the others. And that's one the good things of the app, because there are many women that doesn't want to tell the other woman, I have urine leaks, because they think that's normal. But if they have the app and they have, like, look, that's something common that doesn't mean normal, but common that more women have, maybe they are able to talk, or just with the app, they start doing something to improve their health, or they go to the doctor. There is said that a woman with urine leaks, since the first day she has it, until she tells the doctor, it takes 6 years.
Yeah.
So when they go, it's too bad. They really have to have a treatment. But if they had told the first day, it's quite easy, 5 minutes a day for weeks, you have improved immediately.
Are you thinking of maybe building a community aspect?
Yeah, that's on the roadmap. It will depend on the funding we get.
Okay, well, good luck with that.
Yeah.
All right, well, this is our last demo of the day, of the conference.
My word.
I know. We're delighted to have Anna Sort with us. She has been on the Health 2.0 stage before, but never as a demo presenter.
That's a first.
You were here as a panelist, because you are a nurse, an entrepreneur, and a serious gamer. So she discovered 7 years ago that she enjoyed making health more fun, and it has been her mission ever since. To accomplish that, Anna created Play Benefit. Their first product offering is Benergy, an app to help you have more energy, optimism, and build willpower by logging information in a subjective way and observing correlation. You'll ask me, why is this in the Unmentionables?
Why is this in the Unmentionables?
Exactly, thank you.
Why?
Yes, well, because some of the logging may involve a Bristol scale, which is used for the evaluation and categorization of stools. So, Anna, if you're ready, we are too.
Thank you. Thank you for the introduction. So my name is Anna Sword, and they've introduced me very, very well. I decided we needed to make health fun in order to have people healthy, have it more attractive. So I developed this app that you can see here right now that's called Benergy, and it's focused on 6 main key points that we correlate to energy as just well-being all over, which is food, exercise, sleep, environment, mind, and bowels. Yes, I said it right, it's bowels. They are very correlated to our overall health and how we're feeling. Doctors have known this for centuries, but none of the apps seem to have it today, so we wanted to include it in ours. Let me explain you a little bit what the Benergy app is about. So this is what we call the journey, and it's the path that you take into a healthier lifestyle. And what we see here is every single one of these dots is an activity. Each of these activities have a little video that will talk to you about one
Bienvenido.
thing.
Hoy hablaremos sobre cuáles son los mejores momentos.
So each one of these videos does talk to you about one single thing regarding one of the 6 steps that I just told you. So this one tells you when you should be eating around the day. So, oh, sorry, I forgot to do this. So when you get to the end of the video, what you always have is a challenge. That's not showing up now. Oh, great. And this challenge, what you do with it is it makes you test what you've just heard. So if you just heard that you should be eating 5 times a day, that's what you do. You go into this little challenge. You set up the times that you want the app to tell you to remind you to eat something, and then the app shows up at those times and tells you things like, hey, did you know that if right now you have an apple and a nut, it's going to help you with the absorption of the vitamins? And then you might go to work, and then you might say to your colleague who's eating a fruit, you might tell them, hey, do you know that if you have a nut with that, it's going to help you with your absorption of vitamins? And then we're not only helping that person that's using the app, but eventually also going to other people that are just around to make their lives also healthier. So another thing that this app has, so besides the pre-made journey, we have something that we called bits. Bits are specific moments in life that require specific tools or specific moments. So in this case, we would have, for example, this is a beta, by the way. I forgot to say that. So this is a beta. It's not on yet. We're probably going to be delivering Benergy to the world in about 6 months. And one of the things that we'll have here is, for example, women health, pains and menstruation and menopause, but also moments like jet lag. If you're going to travel around the world and you might have jet lag, you can activate the jet lag bit, and then it will tell you tips and tricks that you can do while you're traveling and when you land, things that you can do in the next following 2-3 days in order to not be as jet lagged. Another thing that I wanted to show you is, for example, a tool. This is an example of a tool that we have, and it's called mindful eating. And what it does is it tracks 5 minutes. You start a timer, and it tracks 5 minutes, and after 5 minutes, it asks you, how are you doing? From 1 to 5, how full are you? And then, if you put 2, you continue to eat. It gives you tips on how you should do your mastication, how you should be eating. And then once you say 3, the app tells you to stop eating and again start eating in about 2-3 hours. So this is a bit what the beads are about, so special moments in time. And then we have tracking. So we didn't want to have, my experience as a nurse, when it comes to databases and numbers, is that you either have the people that's like super against inserting databases and doing numbers and stuff like that, and the people that get obsessed with it. None of these profiles suited what I wanted to achieve. So what I did is have an app that asks you, how well did you eat today? And then you can say, not very much, a little, quite good, or very good. So you can have a sort of place where you say what you think of yourself objectively. Because what I wanted to achieve was not to get someone that's up here, but someone that's here to see their progress. Okay? And we also log in a Bristol scale, as they said. We saw that there was a huge gap in stools and digestive system knowledge. So what we wanted to do was to have people's intestines covered by giving them Granny's remedies in order to cover this. So they could see that in their charts. And then they can keep track of themselves and see how they are doing, see if their mood affects their digestive system. And that's pretty much it. Here they can see their tracking, they can give us feedback on what they think, and that's it.
All right, well, thank you, Anna. Congratulations. Come and join us on the couch. I'll leave you my
I was going to
Oh,
move
that's
up.
nice, thank you.
I'll go here. Don't want you to feel ostracized. One of the questions I was wondering is, how do you get to your users? I mean, I understand that we need to be more in touch with our bowel movements, but how do you get to the people, and how do you? I mean, you said it. You're not trying to reach the people who are already very aware of these things. So how do you get to them?
So I'm going to answer this question in two parts. The first one is, when you have a problem, you want a solution. If you Google, if you have a problem right now and you go to the App Store and you say bowels and diarrhea and stuff like that, most of them are fun joke apps. So you want to find an app that actually helps you with that. As Elena said earlier, those are things that people don't talk about. They keep it to themselves until it might be too late, or we just go over with it. We might go 3 days with diarrhea hoping that it just goes away. So people need answers for that, and they need an app that helps them with that. And there's a lot of natural remedies that work. Granny's remedies are not there because someone spawned them, but actually because they work. Thing is, which one works for you? Does a yogurt a day work for you because it just works for you? Or does it work for you because you have a little mild lactose intolerance and therefore it just sort of washes off? So this is one of the things. The other thing is that our target for the market research that we did was a female, 35 years old, and so on. But the thing is, we did an Indiegogo campaign, and we saw that we had 50% male interest and 50% female interest. So now we're trying to listen to these male backers and see what they think of the app and what we could improve to sort of be more in touch with them. So yeah, that's pretty much what I wanted to say regarding your question.
So I was just wondering, well, if you're thinking about that in I mean, how much usage have you had so far? Obviously, it's fairly early stage, but how much usage have you had? And within that, what have been the most popular aspects of the tracking or the bits? You know, what are you finding that surprised you in the early adoption of this?
So we run a focus group with this app because it's very early stages.
Sure.
So we still have about 6 months to go or so. But we run a very a short focus group, and the one thing that we got told was like, the app doesn't know who I am. The app just sends me on this journey, and it doesn't listen to me. It doesn't